Okay, so it's now my pleasure to introduce the final speaker of our session, Dr. Arata Azuma from Nippon Medical School in Japan will present a talk entitled Post-Marketing Surveillance of Pirfenidone for IPF in Japan.
Thank you for Professor Luca and the organizing committee member giving me the opportunity to present a Japanese post-marketing surveillance of Pirfenidone for idiopathic pulmonary fibrosis. This is a conflict of interest list. Oh. Repair. This is a list of conflict of interest. Co-investigator. This is a co-investigator. Introduction of the Pirfenidone is antifibrotic agent approved in Japan in the end of 2008. Under the direction of the government, we conducted the post-marketing surveillance, enrolling all patients who initiated the Pirfenidone therapy between the end of 2008 for 1 year. Objective of a Pirfenidone post-marketing survey is a gain of understanding is mainly a safety profile and efficacy of Pirfenidone in the treatment of IPF in the clinical setting. The patient and the method. The diagnosis of IPF is based on the Japanese guideline. This is a completely similar to evidence-based guideline and in the worldwide, and we use a staging, a grading method, a severity of IPF. Classified in table 1 is a small, and the grade 1, 2, 3, 4 based evaluated the resting PaO2 and combined with the exercise assessment of desaturation under the 90%. And the adverse event evaluated the MEDRA by using MEDRA, and the acute exacerbation is assessed by the treating physician based on the worldwide criteria of acute exacerbation. Change of vital capacity regarding efficacy profile based on the at the baseline and at least once during the treatment, 2 points, and for at least 4 weeks or longer. This is efficacy evaluation set. You may know you want to know vital capacity predicted the relationship between staging 1, 2, 3, 4. As you can see here, staging 1, 2, 3, 4, the gradually decreased, but the variety of vital capacity. So we recommend 70% or more vital capacity is more effective in the Pirfenidone, but this is an enrollment of stage 3 or 4 as a major population in the post-marketing surveillance. Background and the limitation is a single arm and a non-control study and retrospective analysis. And many, you may have a question of why you recommend, why I recommend mild and moderate stage is more effective, but such as advanced stage of IPF is enrolled in this study. There is two reasons. Many patients with highly progressive disease who have been waiting for a launching of drug, and after post-marketing survey and the initial 1 year is a advanced stage of IPF is enrolled this study. And furthermore, in Japan, and the government subside covered by the advanced stage, stage 3 or 4 is covered by the insurance system. So many of them, after advanced stage, to treat with this pirfenidone. Many patients advanced stage enrolled, and so these are two major reasons of the post-marketing survey of advanced stage of IPF. The number of patients is enrolled, and we gathered now 1,500 people enrolled, but collected the information approximately 1,000, and the safety analysis set in 973, and the efficacy analysis set for the acute exacerbation is approximately the same. Vital capacity change at half of them, and more than 6 months treatment is 355. This is baseline characteristics. 75-year-old or more, older age is 30%. This is excluded in the clinical phase 2, phase 3 trial. This is a first experience in the treatment with the IPF. And stage 4 is a very high rate, and under the 50% predicted vital capacity is 16%. This is excluded in the clinical trial. And particularly, you're looking at the 1,200 milligram and 1,800 milligram a day is half of them for evaluate the efficacy evaluation, and the safety analysis is approximately 1/3 population. And this is a population of reason of discontinuation of pirfenidone. 1/3 population is adverse event related to the drug, mainly the decreased appetite, malaise and the nausea, abdominal discomfort is a major reason of the discontinuation. Photosensitivity reaction is not so much because of the awareness of education to the protection of the sunscreen, using sunscreen. This is a very preventable. But GI trouble is a main adverse event. And as a reason of the progression of IPF and the acute exacerbation is 25%. And the request of patient, this is mainly the financial system, financial reason of the discontinuation reason. This and the course, according to the grading severity, as the death rate is increased, stage 4, as half of them died, and the vital capacity at the baseline at under 50, as a 44.5% died. But interestingly, cancer, with lung cancer, reason of the death is it may be a small number of ever we reported. major adverse drug reaction is at least decreased appetite and nausea, malaise, and abdominal discomfort. This is photosensitivity reaction is 15%. This is diminished, decreased by the protection. The serious adverse event defined by the death or the hospitalization is a small number of. This is not related to aging, severity grade, not associated with adverse reaction, but tended to be a female highlight of adverse event. The GI travel is protected for PPI, using PPI and the H2 blocker and gastromucosa protective drug and kinetic drug. So using these combination is a significantly reduced incidence of a GI travel. Incidence of acute exacerbation, according to the staging rate of acute exacerbation, it increased. The baseline vital capacity has decreased. Rate of the acute exacerbation, it's increased. Change in vital capacity, more than 6 months duration is 355, decline in the 4.5%, and more than 12 months, the decreased number of, and the 2.62. This is a line of decline of vital capacity. Mean value is 50 ml. This is according to the forward dropout. If the patient can continue to treatment, we recommend that continue to maintain the diminished decline of vital capacity. In conclusion, this is an interim analysis of post-marketing surveillance. Advanced stage and more severe IPF is enrolled in the study. A reduction in the initiation of photosensitivity. This is a preventable, but GI symptom is a major reason of the discontinuation. We need to overcome these adverse event to continue to the treatment, even in the advanced stage of IPF. 973 patients we need to follow more. Next meeting, we will the final report. This is final slide. Thank you for your attention.
Thank you very much for a very nice presentation. Questions from the audience, please.
Data. You say that the cause of death was IPF in the large majority. Was it an IPF exacerbation? I mean, by definition, if one dies, it's the most severe exacerbation of the disease. So did you include this in the exacerbations?
Not all acute exacerbation. The progression of respiratory failure died. Not acute exacerbation, but finally...
So how did you distinguish the two? Were the data of people who died of an exacerbation included in the exacerbation or not?
Included.
Included?
No,
Include.
you said severity, acute exacerbation, and rapid progression. So 2 conditions were associated, yeah. Both contributed to death. But there are, acute exacerbation is a increase of symptoms within 4 weeks. So that is acute deterioration and acute. Rapid progression probably is a rapid progression beyond this 4 weeks limit. Is it correct, Dr. Azuma? How did you define rapid progression?
Yeah, maybe finally the respiratory failure died. But this is including acute exacerbation, finally. But respiratory failure and percent vital capacity under 30%, well, inhalation of the high concentration oxygen died.
Okay. And the second question is, did you ever had autopsies in those? Do you have any autopsy data? What is, at the autopsy level, the main cause?
Now I have no data.
Hal Collard next, I think, was it?
Okay, thanks. Arata, thank you for presenting that. It's a lot of work. I have just a question for you and a comment or concern about post-marketing data like this. I mean, one of the challenges is getting adequate follow-up. So you had more than half of your population that didn't have a follow-up FVC, right? So can you comment on that population? Was that population of patients different from the population you had follow-up data in? Because if there are differences, it would make us worry that our estimate could be off. Does that make sense, what I'm asking? The group of patients you didn't have FVC follow-up data on, were they different? Were they older, or did they have more, I don't know, exacerbations or deaths, or were there other features that were different?
Post-marketing include general physician and all treatment people is included. So the measurement of the vital capacity is not mandatory. So some expert in the before and after compare with the, they can compare with the vital capacity, but some of them are the lack of before measurement. So this is excluded, dropout in analysis.
Okay. It might be worth looking at that group that you didn't get the FVC on, just to compare them to see whether they look different or not.
Yeah.
Yeah, thank you.
Thank you for a comment.
I have a comment on the patients with severe disease that were treated now in Japan predominantly. I believe when you analyzed in a post-hoc analysis the data from the phase 3 trial, the Japanese phase 3 trial, you found that those who had mild and moderate degree of severity responded better to pirfenidone than those with advanced disease. So have you any data in your post-marketing study to also support that those with a stage 4 did not respond as well as those with stage 1, for instance, just to make an easy comparison?
I have no accurate data, and there is no compare with the placebo group. So,
no, but you could compare as mild disease with advanced disease, those who have stage 1 with those who have stage 4, where there were more deaths in stage 4 than in stage 1, for instance. And I know that it's not really feasible because they may of course they are anyway not at high risk, but on the lung function, you could compare the lung function decline.
So we need to compare the patient who do not treat with the pirfenidone, compare with the decline of vital capacity. I have no data yet. We need to follow up.
Great. Thank you. I think there are some questions in the other room, so if we can switch to the other room now.
Thank you. Thank you, Professor Azuma. I have a question. How do you explain the statistically significant greater incidence on side effects on the more severe people? Because this is a unique data, because in the clinical trials, the more severe patients are not included.
Your question is, this population is include the clinical trial that population?
No. My question is, how do you explain the greater incidence, statistically significant, in side effects in your population in more severe patients? And I commented that this population is not included in the clinical trials published till now.
Yes. And the clinical trial, side effect. You may mention it in the slide.
Exactly. This is what I mean.
Adverse event, instance of adverse event is almost same, not related to the severity and the advancement of vital capacity decline. Exactly the same, not significant difference.
Okay, thank you.
The people who were not able to tolerate post-marketing of the Pirfenidone, do you have a feel of what happened to their vital capacity in terms of their decline?
Beg your pardon?
So there were people, you showed the data, the post-marketing analysis, this tolerability, you ascertained it well. But there were still some patients who didn't tolerate it and they did not take the Pirfenidone post-marketing. So what happened to those patients? Do you have a feel for their slope of vital capacity decline in them who did not tolerate or take Pirfenidone?
Yeah. Main reason is GI discomfort and the advancement of.
No, I understand, but do you have a feel for what happened to them after they stopped Pirfenidone? What happened to their vital capacity?
Yeah. I have no data.
No data.
Yeah.
Okay. All right, I think we'd better move on. Thank you very much.
Thank you very much.